This webinar is brought to you by the New Hampshire Training Institute on Addictive Disorders. You can access the recording of this webinar on our website at NHADACA.org within our webinar library. After completing this webinar, please complete the quiz and evaluation if you are interested in receiving a certificate. You can find the quiz and evaluation on our website next to the Watch Now button you selected to view this webinar on our website. If you are a member of NHADACA or NADAC, the certificate for this webinar is free. If you aren't a member, the fee is $15. You will receive a certificate worth 1 CE once you have completed and passed the quiz and paid for the webinar if applicable. Through the New Hampshire Training Institute on Addictive Disorders, this 1-hour event is pre-approved by the New Hampshire Board of Licensing for Alcohol and Other Drug Use Professionals, as well as NBCC. If you have any trouble viewing this webinar, audio problems, or have any technical questions, please contact us at 603-225-7060. Please email any questions regarding the material you see today to the email address listed below. All right, so ASAM Just the Basics. This is a huge challenge for me. This is ASAM in an hour, which I've never even attempted. So we're going to get right into it. Here's my contact information. Email is the best way to reach me. I will certainly respond to any cell phone messages or text messages. But please note that if you do call me on my cell, I probably won't answer, but I will respond to any voicemail. So our objectives today, our main objective really is to be able to articulate a clear understanding of the spirit of ASAM, right? So we're doing an hour of ASAM. Really what I want you to be able to do is understand ASAM from a philosophical sense. Understand the basic premises, ideas, values supported by ASAM. And we'll talk a lot about that, but that's really all I'm hoping you can wrap your head around in this hour is just what is ASAM and how do I embrace ASAM thinking and think in a way that is supported by ASAM. Also, we'd like to be able to help you have a better understanding of how an assessment can be used for care planning. We want you to be able to gain confidence in understanding the 6 dimensions of ASAM, be able to identify the different levels of care, and demonstrate a basic understanding of continuing care and transfer discharge criteria and how to use them in conjunction with a care plan. I'll be using the terms care plan and treatment plan interchangeably throughout the training. So program-driven treatment, right? This is something that we do every day, that is done every day in our state and nationally. Program-driven treatment is treatment as usual. It's really the way that the culture of SUD treatment has what it is. So these are program-centered treatment plans. These are treatment plans like the individual will participate actively in all aspects of the program. Terms like the patient will complete the program. They will participate actively in all sessions, things like that. Very, very programmatic treatment plans that are can be really for anyone and are used for anyone. Length of stay is fixed. It is based on the curriculum. So when they complete this many sessions and when they have completed these specific lessons or psychoeducations, they can graduate, if you will. Discharge is done after the patient graduates or very close to. So when someone is getting ready to leave, it's kind of a shuffle to say, okay, what are we going to do with this person? What's the recommendation? Well, let's recommend they go to outpatient counseling. Here are some phone numbers we can give them. All patients receive the same treatment interventions, right? Despite their uniqueness and their unique goals or unique problems, all patients are given the same interventions. Many treatment plans are to complete the given level of care, right? I worked as an auditor for a fairly significant amount of time, and many treatment plans I saw were to complete the given level of care, which was kind of counterintuitive. And what this all leads to a lot of times is patients do time versus doing treatment. They don't engage because there's really no sense of them in the process. They're just doing what everyone else is doing. They're doing what is already predetermined for them, despite their their unique needs and unique problems. Patient-centered care. So this is really the cornerstone if we're talking about the philosophy or the spirit of ASAM. This is patient-centered treatment plans. These are care plans that are, based on what the patient's specific problems are and what the patient's specific needs are, not what our interpretation of those are, what their specific needs are or problems. Length of stay is based on the patient needs and the progress with treatment goals. So if we want to align ourselves with mental health and with biological health, with healthcare, we really have to follow the same kind of parameters and hold ourselves to the same standards. So if I have active psychosis and I'm hearing voices, and I enter into a treatment facility to address that, and I get on medication, and this is the first time I've had this, and I say, well, doc, I'm ready to get back to my environment. I got to see how I can function on these meds in my environment. I have to learn to live with this illness that we've discovered, this kind of first onset, and I'm ready to go. And the doctor says, well, this is a 28-day program. You've only been here 2 weeks. I'm glad these problems have gone away and these symptoms have gone away, but this is a 28-day program. It's ludicrous, right? It's unethical in a lot of ways, and the same goes for the biological health care. We have to be good stewards of our resources, and we have to treat people until they are no longer symptomatic versus a fixed length of stay. Discharge begins at intake, right? We start looking at the next level of care along a continuum when someone comes in. So during that assessment process, we assess what their liabilities are, what their assets are, and we can use those in the beginning to start to say, all right, well, this person's here. Logically, what might make sense is this. And we start to already build that continuity of care plan during the beginning of treatment versus the end. Continuing care is based on clinical assessment. Hopefully we'll be able to touch on this, but we're determining if someone is appropriate for ongoing care based on their progress and the resolution of their care plan. So have they resolved the problems that made them appropriate for whatever level of care they're at? Have they achieved the objectives set forth in their care plan? No, if they're still working on things actively, then we retain them and we continue them at the level of care. Discharge transfer decisions are based on clinical assessment. This is the same kind of thing. We determine whether or not to discharge or transfer someone to a less intense or more intense level of care based on the clinical assessment, right? So if they've completed all the objectives in their treatment plan, there are no new problems that have cropped up that are being treated at that current level of care, we can start the process of transferring them to a less intense level of care in that case, okay? Discharge transfer, I already went over that. Treatment plans should be created to resolve problems that made the patient appropriate for treatment. I can't stress that enough, okay? The treatment plan is what drives the care, all right? And once they resolve the problems, that's really what's driving the person's need for treatment. We need to look at, moving them into a new level of care. So this isn't my slide. This is David Mealy's, used with permission. If you haven't had a chance to see David, he's awesome. He's a great presenter, and he literally wrote the book on this. So I asked for this slide because it's a really good slide. It illustrates, again, this is more of the spirit of ASAM, the kind of philosophy behind it, understanding the values of ASAM. So we begin at the top of the circle here with a biopsychosocial assessment, a dimensional assessment. We identify problems and priorities. We assess the severity of their illness as well as their level of functioning, right? We're looking at problems and resources and strengths. We create a plan with the individual, and we prescribe an intensity of services, and that's through modalities and levels and things like that. And then we take that plan and we put it back through. How are they progressing with treatment? What's their treatment response? How are they responding to the interventions that we've prescribed for them? And again, what's the severity of illness at this point, and what's the level of functioning as we reassess and move back to the top of this circle? And we continue to move through this as we. David says all the time, continual reassessment, right? We want to be continually reassessing someone. We want to get a multidimensional assessment. Patients appropriate for treatment, really, they need to meet the diagnostic criteria for a substance use disorder based on DSM-5. We want to conduct a comprehensive biopsychosocial assessment organized based on the 6 dimensions. We want to assess the severity of their illness as well as their level of functioning, identify problems within each dimension. It doesn't mean every dimension needs a care plan. That's the way, it used to be suggested at times. That's really not the case. We want to address the problem that's making them appropriate. Focus on the here and now versus historical data. And this isn't a scoring, but an identification of problems and severity. So I really want to stress this. We have standardized assessments like, I hate to pick on it, the ASI, right? Everyone hears that, they cringe. I used to pick on the ASI too, but I learned in time, it's not about, it's about using the assessment and not letting the assessment use you. So yes, if I sit down with the ASI and I say to an individual I'm assessing, do you have close reciprocal relationships with the following people in your life? And I start listing off people. They are going to look at me and ask, why am I asking questions in such a way? I'm not building any rapport. I sound starchy and robotic, and I'm not 100% sure that they know what reciprocal means, right? But if I sit down and I say to someone, hey, tell me about who's in your corner. Tell me about who's got your back. Tell me about who you go to when you have a problem. What does support look like to you, right? I get this rich narrative of information that I can then use. Also, if I look at the ASI and I say to someone, how troubled or bothered have you been in the past 30 days by problems with alcohol? And I give them this little scorecard and they say extremely. Great, I know that they're extremely bothered, but I don't know what that means. I don't know if that means that they're extremely bothered because their probation officer is telling them to come see me and they're worried about getting violated. Or I don't know if that means that they have had their 4th bout of pancreatitis that has landed them in the hospital, and they keep going home and they keep returning to drinking, right? Those are very, very different problems that if I only record a score or a number or a word, I am not getting that information, right? So an assessment is really the cornerstone with which treatment begins. It's not just something that we use to assess where someone should go. It is the beginning of treatment, and it is used throughout treatment, and it is the first building block in this golden thread of documentation and care. Motivational interviewing is very important. The 3rd edition has some pages in there about specifically about using motivational interviewing during an assessment. I strongly suggest you read the 3rd edition if you haven't already. There's, all throughout the book, there's lots of other stuff that can be utilized during assessment, but these are the pages that specifically speak to using motivational interviewing during an assessment. The 3rd edition is like my favorite new edition of a series of books. It's so well written, it reads very easily, and I can't recommend it enough. There are some suggestions on the slide of ways to start that conversation. So a discussion question, all right? ASAM supports the use of programs that have fixed length of stay. Is this true or is this false? The answer to this question is B. This is false. So determining level of care, all right, we want to consider the patient's assets. Where, do they have supportive individuals in their life? Do they have strengths? Do they already have some resources? What's their level of understanding of their disorder? What's the readiness to change? All these things that we're gonna talk about. We want to assess dimensional interaction. We'll talk about that. We want to determine priority need, and that might, we touch on in a deeper ASAM training, as well as addressing imminent needs and imminent danger, right? Imminent danger is a concept that a lot of people have trouble wrapping their head around, but we want to understand, is this person going to seriously injure themselves or someone else within a week? or is this someone that imminent danger is not there? And that's a much longer training to touch on all that. But we want to be able to understand it. Understand what is the least restrictive level of care that the patient would need to resolve their problems, right? We want to be good stewards of resources. Increase in severity of illness should translate into an increase in intensity of services. Now, that doesn't necessarily mean that increase in severity of illness always means a more intense level of care. It could mean a given level of care is augmented or enriched in certain ways to help the individual, but oftentimes it does mean a more intense level of care. The pages in the book that cover what we talked about on this slide are here. I very strongly suggest you read through them. The ASAM book has every answer you need to any question you have. It's very comprehensive, but it's also very easy to understand. So remember, it's not, when talking about assessment, it's not the wand, it's the wizard. You guys are all clinicians, you're trained, you have skills. This is the fun artsy part of what we do. Use your clinical skills to get the information in a way that builds rapport and also gets real information, not just numbers, not just scores that you can write down, that the patient is really concerned because they have a new child and they overdosed and they want to be there for their kid because their father wasn't there for them or their mother wasn't there for them. Boom, we have so much rich information versus the individual has a opioid use disorder, right? I've seen that as a problem statement on so many treatment plans, right? So we want rich information. So our ASAM dimensions, we're going to go through these very quickly. I apologize for the speed at which I'm moving, but we have a lot to cover. So dimension 1, all right? We want to assess the risks associated with the patient's current level of intoxication or withdrawal, right? We're really talking about 2 or 3 different things. We're talking about intoxication, we're talking about withdrawal, and we're also talking about the potential for withdrawal, right? So if we have someone who's acutely intoxicated or is just kind of coming out of intoxication, the intoxicant is leaving their body, there is potential for withdrawal there, right? They may not be meeting criteria for a withdrawal syndrome. They may not even be scoring on a CEWA or a CINA or a COWS, but they may, we know that based on their history and based on what they're telling us, that they are at risk for the potential for withdrawal, all right? We want to understand what are the risks, right? If the person's intoxicated, are they driving home? Are they biking home? Are they going home to take care of small children? What's their level of intoxication, right? Oftentimes, I worked at programs early on where it was like, if someone was, they blew a .08, we were like, all right, we got to send them home. We can't intervene with them. That's a great time to intervene with someone. That's a great time to kind of talk with them. That, a .08, most people are pretty functional. I mean, it's amazing the things that our clients can do while under the influence. So, I would say have that intervention with them. What are the risks associated with withdrawal as well? Substance use history. We want to know how much, how often, how and how long, okay? We want to understand the recent history of their use. We also want to, we may delve into the past, but most importantly is the most recent history of their use. What's their pattern been like recently? Are they experiencing any current withdrawal symptoms? What's their withdrawal history? With ASAM, here and now is always going to trump history, right? I want to respect history, but just because someone has a history doesn't necessarily mean that I want to overprescribe services. Case in point, an individual comes in, they have a history of an alcohol withdrawal syndrome. They've actually been hospitalized twice for alcohol withdrawal. They've been sober 20 years. They were active in AA. They stopped going, 2 years ago, and they started drinking 2 weeks ago. They've been drinking 6 or 8 beers every other day-ish, and their last drink was 3 days ago. No signs or symptoms of withdrawal. Just because of that history, we don't want to say, all right, well, you have this history, you need to go to an inpatient program. No, we're gonna assess the here and now. We're gonna look at their pattern of current use. And the converse is true. If we have someone who has no history of an alcohol-related withdrawal syndrome, but their use is very significant. They're tremulous. There's all kinds of stuff going on. They're scoring very high on a CWA. You know, the recent history speaks to it. You know, we may want to look at an inpatient treatment program at that point. CWA, CNA, COWS, these are all clinical assessments to assess withdrawal. I strongly recommend that you use some sort of clinical assessment to assess withdrawal. It's very helpful and important. And you can consider the patient for withdrawal management services. Dimension 2, biomedical conditions and complications. These are current physical illnesses, chronic medical conditions, pregnancy we want to look at here, multidimensional interaction, special attention to dimension 1. So if I have someone who in dimension 2 reports a familial seizure disorder of origins unknown, but they've dealt with it their whole life, right? And they're withdrawing from opioids, we know that opioids in and of itself is not going to cause a seizure, but for this individual, an overexcited central nervous system that we see with withdrawal from sedatives is very likely to create a scenario where this person has a seizure. Okay, so there's an interaction here. Is what I'm trying to point out. All right, we want to pay attention to that interaction as well. Medical concerns related to use, right? Is there a gallbladder problem? Is there a history of endocarditis? Is there an abscess? Is there, you know, any medical concerns that are related to the person's use of the substance? All right. Harm reduction measures, right? We have to get away from this notion that harm reduction is not treatment. Harm reduction very much can be and is treatment. You know, we want to keep people engaged and keep them alive, is what I mean. All right, dimension 3, emotional, behavioral, or cognitive conditions and complications, okay? Here we are talking about just that. We are talking about any current emotional, behavioral, or cognitive conditions that could interfere with treatment, okay? Are they emotional because of a recent breakup, death, you know, something that has happened? Are there behavioral concerns here as well? Is there, you know, some personality traits that we're looking at? Is there a cognitive condition? Is there a TBI? Is there an acquired brain disorder? Is there a learning disability? Is there some sort of cognitive condition? Or are there, you know, mental health problems on board that could create problems or interfere with treatment? Or that need to be treated. We'll talk about that. We want to assess chronic conditions. We want to look at the relation of symptoms to SUD, right? I am not a mental health professional. However, I have experience treating anxiety as it relates to an SUD, right? We know that a craving is a tremendously it's a tremendous anxiety-producing situation for individuals, right? When they're craving and they're you know, trying to find a way to not use, it creates so much anxiety for the folks, and we address that anxiety from the scope of an SUD, right? Same thing. We have folks that report, you know, their mood is off. Well, their brain chemistry, they're in that kind of post-acute withdrawal or protracted withdrawal state. Where their brain chemistry is really messed up, and you know they're having trouble with mood. That's very common. We even see some kind of dysthymia, right? They're anhedonic. They're not experiencing pleasure. But we also want to be very wary of organic mental health and psychiatric problems that stand alone, right? That can be primary in a lot of cases. So we want to keep our eyes open for that as well, but we also want to look at, you know, what is associated with the SUD, right? We want to monitor symptoms. We want to, you know, I've had a lot of folks that I've worked with where they're anxious, you know, and it's a lot of that brain chemistry stuff, and also a lot of life situation stuff. And if we're identifying that the anxiety has a focus, it's not unreasonable worry and inability to feel relaxed, and some of those things that you see. it's getting better with abstinence, and it's getting better with some of the interventions that are related to substance use. We know that may be directly related to just SUD. And if the symptoms get worse and continue and are not focused on a specific thing, then we need to work on that from a different perspective. So making sure we're understanding what's going on for individuals. We want to get a mental health history, okay? Here it's important, yes, we want to get a history, but if someone's reporting a major depressive disorder, or they report being diagnosed with a major depressive disorder, I should say, it doesn't mean we automatically go, okay, well, they're not appropriate for this level of care, or, we need all these things, or we need to get them medicated, or whatever it may be. We want to talk with them and find out, well, what's going on now? Well, any trouble with mood? Yeah, my mood's a little off, any feeling of hopeless and helpless? No, I don't feel hopeless. I don't feel helpless. I don't feel, there's no exaggerated sense of guilt. There's no sleep disturbances. Their ADLs are fine. Like, everything's okay. And we get from that history that was 4 years ago. They were diagnosed after their wife, husband, mother, or father died, and they hit a very low point in their life, right? So again, we respect the diagnosis, but we don't want to over-prescribe services because of a diagnosis. We want to look at what symptoms are they experiencing currently, all right? And we want to be aware of that, monitor symptoms, but we want to look at the here and now. What's their treatment history for a mental health or psychiatric problem, or whatever it may be. Traumatic brain injury, I started this one. We want to ask the right questions. Oftentimes we don't. And so we want to ask, have you ever, experienced a blow to the head and not remembered anything? Have you ever been ill after getting, after bumping your head pretty good? And we may find out that someone did in fact have a TBI. We want to monitor symptoms. I can't say that enough. And look at a multidimensional interaction, right? We know that folks often self-medicate when they are experiencing an untreated mental health disorder, so that's going to influence other dimensions, okay? Dimension 4, readiness to change. This is the dimension I kind of geek out about. This is the motivational interviewing dimension. We can assess both mental health and SUD here, right? How ready are they to address an underlying psychiatric or mental health problem? What is their level of awareness of the relationship between negative consequences and substance use? Case in point, I worked with a woman I was doing an assessment with, and I was doing a lot of motivational interviewing during the assessment, and she was kind of at the point where she was telling me why it wasn't that bad, and she'd been shipping for a long time, and the past year was really in full-blown addiction, and was using IV fentanyl. And she was explaining to me why it wasn't that bad, and I was listening, and she said, my teeth are fine, my looks are fine, and I don't have any scarring, and she was pointing to where she injected. And I should point out, on that same arm, she was missing her pinky finger and her ring finger, and that was due to an infection she sustained from IV use that spread to her hand, and she had to have those fingers amputated. Now, I had to recenter myself because I was saddened by this cognitive distortion, and thinking to myself, geez, that's something I would consider a scar, But her perception is what I need to embrace, and so, but I tell that story, and I can go on about that story, but I tell that story to illustrate that there's often a vast disconnect between the reality as we see it and the reality as they see it, the disconnect between their understanding of the consequences of their substance use. So it's not just readiness, we're talking about willingness, ability to change their addictive behavior, or behavior in general, right? We're talking about self-efficacy here. We're talking about self-confidence. We're talking about very deep-rooted stuff for folks. And hopefully we've had the pleasure, or you've had the pleasure to work with individuals who the work essentially a lot of times does itself. They have self-confidence. They say to you, I think I can do this. I've overcome other things in my life. My family's here for me. I have a lot of strengths. I did a lot of things. I can do this. Versus the clients that we see all the time who are like, there's no point in even trying. I've tried before. I didn't even graduate high school, you know, I'm going to end up working dead-end jobs, and, you know, I'm no good, and I might as well keep using it. At least it gives me some joy, you know. That very low level of self-efficacy is very, very difficult to work with. So we need to understand that, like, what's the level of self-efficacy, what's the level of self-confidence of the individuals we're working with. And if you're not using a readiness ruler, it's a tool that I strongly recommend. You use a 0 to 10 scale, 0 being not at all, 10 being the extreme, and you describe that to them. And you can do it however you want. I do mine with importance, confidence, and willingness. So how important is it for you to make a change? 0 being not important at all, 10 being it's absolutely next to eating and breathing and feeding your kids, it's the most important thing. You know, where do you fall on that scale? Well, I'd say it's a 5. Great. Why not a 4? What made you say 5? I don't know. It's in the middle, and you know, I got to get this done. I got to do something, I guess. All right. Well, what would it take to make it a 6? All right, and then you move on to confidence, right? How confident are you? And then you move on to willingness. You know, 0 being you're not willing to do anything. 10 being, you know, you'll go stand on your head in the corner if I tell you it'll help you. You know, how willing are you to take some suggestions or whatever it be. And then you can use that and reuse that throughout your time with individuals to understand, because that readiness to change will ebb and flow, and that confidence will ebb and flow, and the willingness will ebb and flow immediately once you get to the point where they're receiving suggestions. I guarantee you that. And that's okay. Understanding what the patient's goals are for treatment, not what your interpretation of what they're saying, and then creating a goal or a problem, but understanding what are their specific goals for treatment or objectives for treatment. Looking at a multidimensional interaction, we'll talk about that. And utilizing motivational interviewing, very, very important here for dimension 4. What is motivational interviewing? I'm not going to spend time here. Hopefully you know what it is. This is what it is. There's a neat video here. If you can copy down the link, it's a funny little video that explains motivational interviewing pretty well in my mind. But familiarize yourself with motivational interviewing. I would strongly encourage it. Dimension 5, relapse, continued use, or continued problem potential. Again, we're talking about 3 different things here, and this is important to explain it. We're going to work from the end of it to the beginning. So problem potential, continued problem potential was put in here by the folks at ASAM specifically for mental health disorders. I use it for continued problem potential related to SUD. So you can talk about, you know, continued potential for DWIs, pancreatitis, enterocarditis, crime, prostitution, like all of these different things, you know, continued problems related to SUD. I do that personally. That's not endorsed by ASAM because this specific continued problem potential was added specifically for mental health. I find it useful to use that SUD piece as well. Continued use and relapse are 2 very different things, and still to this day, while we are speaking, there's somewhere in New Hampshire, someone is addressing a continued use problem as a relapse problem and doing, in my opinion, a client a disservice, right? Continued use, when someone comes into treatment and they say, gee, I don't really want to stop, but my husband wants me to stop, and they think it's a problem, and I don't really think it's a problem. And we say, great, come into our program. You know, we have a no-use policy. You can't use alcohol while you're in here, and this is what we're doing. And they come in and they drink, and we give them a relapse prevention plan. And I think the patients a lot of time are thinking, are they not hearing me? Am I not saying it correctly? Like, I don't really want to stop drinking. So this is someone who's not relapsing. They're continuing to use, right? And we have people a lot of times who will say, yeah, I really want to stop. I really want to stop. And actually what they're continuing to use, because we're giving them resources and they're not using them. Oh, the dog ate my homework. Oh, I didn't call because I forgot all about it. You know, so we have to be able to identify what is a continued use problem versus a relapse problem, right? And oftentimes with continued use problems, someone's in an IOP program and they continue to use, and we say, well, you need more help. We're going to send you to a residential program, and we take up a bed for an individual that's more appropriate for that level of care. And we're also frustrating this individual as far as their care goes, because they're like, great, now I got to do this, 28-day program, all right? So we want to be very wary of that. Oftentimes, continued use problems can be resolved in a less intense level of care. As long as there's no imminent danger, we can say, well, gee, look, IOP is not really working out for you. You're not really engaging in the process, and you're continuing to drink. Why don't we meet weekly on an outpatient basis, and we can kind of talk more about this there. So we have to look at that. It's very important to address the two differently. What are their strengths? This is a place where we have folks who have that kind of ability to think about their thinking, that metacognition. They can process their thoughts. Others, not so much. So we want to be wary of the strengths that people have. What's their level of insight into their illness? Can they manage their cravings? Most people, we start to teach consequential thinking, and they're already doing it, right? So what's their level of strengths? What do they have already going for them? Understanding relapse versus continued use, I can't belabor that enough. Making sure that we're addressing them differently. Relapse issues are recovery and relapse prevention. Continued use are discovery and dropout prevention. Let's keep them engaged, and let's help them discover that this is a problem for them. Relapse history, thoughts, internal dialogues preceding a relapse. Is there an internal battle? Relapse doesn't necessarily mean a more intense level of care. Continued use could mean a less intense level of care. Language should be less intense, not lower, but at any rate, a lot of folks, that I've worked with, they find themselves using, or what they describe to me is, they're no longer thinking about using that gets them to pick up. They're so stressed out and tired of thinking about not using, right? They're in this internal battle, and they give up not because they want to use, but because they want to stop fighting with themselves. And when they pick up, it doesn't do a lot for them. When they use, or when they have a flare up, it doesn't do a lot for them, but at least it stops that internal battle. And that's what they describe a lot of times. So is that internal battle happening, or is the person just using? Is there awareness of cues, triggers? Case in point, I had an individual alcohol use disorder, cannabis use disorder, doing great on the alcohol, the classic, cannabis wasn't that bad, I didn't, get into fights or, cause problems when I was smoking, I played video games and ate too much. But they were abstinent from cannabis, and they had, used cannabis, came in and told me about it, and I went over to my neighbor's house. He was the one I used to smoke with all the time. I'd been avoiding him, hadn't been over there in weeks, but out of nowhere, I don't know what happened, I just went over, and it's funny, you always ask those questions, well, what happened? I don't know. Next thing you know, I was over there. That's always the response. So I always walk it back. Well, start me off in the beginning of your day, and I walk through the day, and come to find out, this person had begun rolling their own cigarettes, right? And this we identified was a huge trigger for them. But he had no idea that this was triggering him until he did some processing. So what's their awareness of their cues and triggers? Multidimensional interaction, right? People with issues on dimension 4 are going to have an increase in a continued use potential, right? They haven't resolved their readiness to change, or they don't have a lot of readiness to change, so they're going to have an increase in continued use potential. A really important question that I always ask in this dimension, or when I'm trying to assess this dimension, is what's the likelihood that you're going to, use today? What's the likelihood that you're going to use in the next 3 days, 4 days? What's the likelihood that, without intervention you're going to use? You ask questions along those lines and see what they say. Harm reduction based goals, right? Safe use practices. Harm reduction is treatment. If someone's reporting to you that they're continuing to use and they have every intention of continuing to use, how are you going to stay alive? What do you mean, how am I going to stay alive? Well, you overdosed a month ago. What are you going to do? Well, I don't know. What can I do? Do you do safety shots or test shots? What's a test shot? You inject a small amount of the dope before you do the rest of it. That way you know the potency. Do you sift your bag to make sure it's blended correctly? You know, what are you doing to stay alive? Continued problem potential to assess mental health. We talked about that. Dimension 6 is recovery environment. So this is where we're talking about, this is where we really talk about the social determinants of health. Hopefully you're all familiar with those. It was a pretty hot topic until, I don't know, a few months ago, then people stopped talking about it. But, you know, we can assess both SUD and mental health disorders here. You know, what's their recovery environment like for psychiatric problems? What are the threats to patient safety or engagement in treatment? What are the resources available to help with recovery? Transportation, childcare, housing, or employment issues, mandates that influence treatment motivation, mandates that influence their ability to get to treatment. Spirituality can be assessed here if appropriate. We look at a multidimensional assessment here. How does Dimension 6, a very poor recovery environment, how does that influence Dimension 5, continued use or relapse potential? And considering harm reduction measures, right? So this is the person, you know, living in the zone in Manchester where they're at high risk. Is the person living, you know, above a bar? Is the person living in a flop house with, you know, 3 other people who are actively using? Is the person living with mom and dad who are supportive but don't really understand? You know, what is the environment like? Geographically, where are they? Geography can change so much. If someone's in the North Country, they're already at a higher risk in this dimension, right? Someone may, but also at the same time, someone may live across the street from the treatment center. They don't drive, they don't have transportation, but we come to find out that the road that they have to cross is 55 miles an hour. There's no crosswalk there, and they're 65 years old and have hip dysplasia, right? So even though we're like, oh, they live across the street from treatment, well, they can't get there, right? So we want to look at all these factors that influence the person's recovery environment. All right, so we've talked about the dimensions, we've talked about the spirit of ASAM, now we're going to talk about the levels of care very, very quickly. So we have early intervention, which is not treatment. This is not considered a treatment level of care per se. This is for folks who don't meet the threshold for a diagnosis, okay? And the pages here describe this level of care very, very well and give you a very good sense of who would be appropriate for it. These are educational services, screening services, expert services, DWI programs, employee assistance programs. This is what we call indicated prevention, right? It's not prevention, it's not blind prevention. It's this person, there's something indicated that this person may need some education before this gets out of hand, okay? Outpatient services, and again, here is everything you need to know. This is our classic, it can be group, it can be individual, you know, most people think of it as a 1 day a week thing. It can be up to 9 hours of services. So if you have a patient who is having a really hard time, it's a particularly difficult week for them, you recommend that they come in 3 times that week, okay? That's an option as well, all right? But this is with credentialed licensed professionals. This is for folks who are diagnosed with a substance use disorder. And again, this can be for folks who with high levels of motivation, high levels of self-efficacy, who maybe the severity of their disorder is less intense, and they can get things done at this level of care. Or this level of care can be for folks who are, working on discovery goals. You know, they are in that ambivalent kind of stage where they're still using and trying to resolve that ambivalence. This is a good level of care for that, assuming there's no imminent danger concerns. It's also a good level of care. There are folks who, and my hat's off to these folks, because they're 5, 6, 10, 12 years, 15 years, however long sober, and they still struggle. They still experience cravings on a regular basis, right? And it's hard for them. And every now and then, their 12-step program or their smart recovery or whatever they're doing is not enough, and they need to kind of go in for what I call a tune-up. You know, it's another set of individuals who this level of care is really good for. So another discussion question. So if a patient reports a history of psychiatric or mental health diagnosis, they always need a more intense level of care. So is that true, or? And we know that this is false, right? While we want to understand a history, we want to look more at symptoms are going to influence intensity of services and level of care, not just the diagnosis. All right, so our intensive outpatient is level 2.1. This is a program, right? This is a whole grouping of services. We have individual, group, family counseling, case management, educational groups, medication management. Hopefully some psychiatric services can be available as well. All these different things, and it's a program. We have psychoeducation, all kinds of good stuff. Multidisciplinary team, credentialed addiction professionals, psychologists, social workers. This is 9 to 19 hours a week for adults and 6 or more for adolescents, okay? So that's the IOP level of care. Partial hospitalization services, level 2.5. So this is for individuals, again, these are all folks that are diagnosed with a substance use disorder. This is, it doesn't have to be at a hospital, and it is an outpatient level of care. So those are often misconceptions with a PHP or a partial hospitalization program, level 2.5. New Hampshire calls them PHPs. So this is really very similar to an IOP, all right, but it's more intense. It's 20 or more hours a week of outpatient services. Typically, this is for folks who have more significant psychiatric or mental health problems, or their substance use disorder is at a higher severity, and they need more assistance and more treatment, more hands-on interaction. So clinically managed low-intensity residential, when you see level 3 or 3 to 4, we're talking about residential. So level 3.1 is a low-intensity residential program. The services are relapse prevention, sometimes motivational enhancement, engagement strategies, reintegration into work, education, and their family life. These are staffed by clinicians, other support staff, recovery support workers, a 24-hour structure with trained staff. So if Bobby has a craving at 2 o'clock in the morning, there's someone there who can talk him through it. Minimum of 5 hours of clinical services per week. So these are programs that a lot of folks they tend to be longer term. They still need to be based on clinical appropriateness. But anyway, these are levels of care that can be used for folks who just have a really chronic difficulty building a support network, utilizing support services. They have trouble in their recovery environment, and things like that. 3.3, we don't have any in our state. Clinically managed population-specific high-intensity residential services. This is actually nationally something that is very lacking. This is a high-intensity level of care for folks with cognitive limitations, an ABD or an acquired brain disorder, developmental disabilities. They have some sort of cognitive condition that makes it very difficult for them to learn along with other patients in a regular patient milieu. So think of this as, kids who maybe need specialized education plans, because if you stick them in classes with other kids, they tend to lag behind because they learn differently. Similar thing here is that you're going to have more repetition in your psychoeducation. You're going to have more concrete examples, and you're going to have a slower pace of things as well. So this is a special population level of care. 3.5 is a clinically managed high-intensity residential program. This is for patients who need 24-hour structure to avoid relapse and using an imminent danger. So this level of care is really supposed to be for folks who are in imminent danger of harming themselves or someone else because of their substance use disorder, okay? And they're not really used like that, and that's what creates this kind of logjam in treatment. And that speaks to that spirit of ASAM, is using these levels of care appropriately. But it's to stabilize that imminent danger so you can move them along the continuum. So this is a whole range of services. These are typically for folks who are more motivated for treatment, but if they meet that threshold for imminent danger, you can certainly bring them in, arrest the imminent danger, do some motivational enhancement therapy and things like that. but this is a very high acuity level of care. This is kind of like, well, we have wait lists for these programs, and that is akin to someone coming in with a heart attack, and we say to them, I'm glad you came here for your heart attack. You need to go on this wait list. Call us every day for 2 weeks, and we'll get you in. All right. This needs to be a seamless approach. A high intensity level of care is like an emergency level of care, really. And because of people staying at high intensity longer than they need to, and because of the people coming into those programs who are inappropriate, we kind of have a log jam. Medically monitored intensive inpatient treatment. This is when you see inpatient, this is when you are including medical folks. So this isn't a hospital level of care, but it's close to it. You're going to have nursing staff, you're going to have doctors available. I believe it's 24, have to be available on call within 24 hours. Level 3.7, these are typically for folks who have an increase in severity in dimensions 1, 2, or 3. It has to be one of those three. You can't be made appropriate because of dimensions 4, 5, or 6 for an inpatient level of care. It has to be a medical problem, either intoxication, withdrawal, a biomedical condition, or a psychiatric problem that needs medication management or needs nursing staff, medical staff. All right. So it's one of those three, dimensions 1, 2, or 3. Level 4, medically managed intensive inpatient services this is like oxygen coming out of the walls. This is like 24/7 doctors. This is a hospital setting, okay? And again, this is people with severe or significant problems in dimensions 1, 2, or 3 that warrant them needing this level of care. It's either a biomedical condition, an intoxication or withdrawal issue, or a psychiatric problem that is so severe that they need 24/7 care and hospital care with medical staff. Okay, so that's the levels of care we've talked about. Hopefully, we're starting to wrap our heads around this patient-centered spirit of ASAM kind of approach to treatment. This understanding that we want to base length of stay on what the patient needs, not on what the program's predetermined ideas are for the patient. We want to start to wrap our heads around and embrace the idea that we are understanding the patient and working with them to prescribe services based on the problems as they're describing. Okay, we've gone over that really with ASAM. The assessment is the cornerstone of treatment. It is the first building block in a series of building blocks for treatment, and it is what we go back to when we want to understand, what a patient needs are and things like that. And we continue to reassess. We practice continual reassessment throughout. All right, and then we went over the different dimensions, and we went over the levels of care. I want to talk briefly about continued service criteria and discharge transfer criteria. I mentioned this earlier. There are 3 criteria in order to be for an individual to be determined to be appropriate for continued care at a current level of care. So they only need to meet 1 criterion. So it is either the patient is making progress but has not yet achieved the goals articulated in the individualized treatment plan. All right. So they're making progress. They're making baby steps in order to reach their goals, but they haven't met the goals articulated in their treatment plan. They've completed a couple objectives, but they are still working on a few other objectives. All right. They're appropriate for continued care. This is really good stuff to use with insurance companies because they're, in the state of New Hampshire, they have to use ASAM or they're supposed to. B, the patient is not yet making progress but has the capacity to resolve his or her problems. All right. They're working towards their goals. I'm not going to read these verbatim. So this one is basically saying, well, they may not be making progress, they have the ability to. So an example of this is that, so hey, Johnny, you were supposed to talk to that that person about being a sponsor. You wanted to do that. Well, I got there and I started talking to him and I was really nervous and I felt like I was asking him out on a date and it was awkward. And, but next time, like, what are some suggestions that I can do in order to do it next time, right? They haven't met that objective on their treatment goal yet, but it's not that they're just standing still, right? So they're not making progress per se. They're banging out objectives, but they're making progress, or they're starting to make progress. Or C, this is a very common one. New problems have been identified that are appropriately treated at the present level of care. Well, I just left residential treatment and cravings aren't an issue for me. And now I'm entering the real world back in outpatient treatment, and boy, cravings are a real problem now. I've now, it's now appropriate to retain someone longer at an outpatient level of care, an IOP level of care, because a new problem has been identified that is appropriately addressed at the given level of care. Happens all the time in IOP, right? Someone has a flare-up, they use a substance that, I didn't think marijuana was a problem. I started using it, and now I can't seem to stop doing it. A new problem has cropped up that can very appropriately be addressed at the current level of care. Transfer discharge, there are 4. Again, same as continuing care. Only one needs to be met for someone to be deemed to be appropriate for transfer discharge. So the patient has achieved the goals articulated in his or her individualized care plan, thus resolving the problems that justified admission to the present level of care. Continuing the chronic disease management of this patient's condition at a less intense level of care as indicated. They have resolved the problems that made them appropriate for treatment. Okay, that's all this is saying. And that, moving them along and continuum to a less intense level of care is most appropriate. B, the patient has been unable to resolve the problems that justified admission despite amendments to the treatment plan. And that's a very important part here. The patient is determined to have achieved the maximum possible benefits from engagement in services at the current level of care, treatment at another level of care, or less intense in the same type of services, or discharge from treatment is therefore indicated. This one really says to me, this is someone who is more doing time in treatment. Listen, hey, Johnny, Jane, we've made amendments to the treatment plan, it's not working out. Like it's not that we're kicking you out. We're discharging you because you're not engaged in this process. So, why don't you, we would recommend continuing in an outpatient setting, or, coming back to us, when you're ready to engage in treatment, right? It's that you're working harder than the patient, right? You're doing more than the patient, and they're not engaged in treatment. They have achieved everything that they're going to achieve from being with you, and either referring them to a less intense level of care, or sometimes discharge altogether, is appropriate. Well, what do you mean? I got to do this for my probation officer. Well, that's a conversation that you're going to have with them, and I'd be happy to have that conversation with you as well. Okay, with the 2 of you, we have a treatment team with the PO. Or C, the patient has demonstrated a lack of capacity due to a diagnostic co-occurring condition that limits his or her ability to resolve his or her problems. Treatment at a qualitatively different level of care, or type of service, or discharge from treatment is therefore indicated. So this is someone who has they come into treatment and, much like we talked about before, because of a co-occurring or diagnostic condition, they need more services. Come to find out that their psychiatric problem is flaring up very, very significantly. They need to get their meds right. They need to resolve what's going on for them. They can't get up and get to treatment because of their depression, whatever it may be. They either need a different modality of services. Maybe they could stay in an IOP program, but they need one that's co-occurring enhanced versus co-occurring capable, whatever it may be. So, but oftentimes we're looking at a different intensity of services. Or the patient has experienced an intensification of his or her problems, or has developed new problems and can be treated effectively at a more intensive level of care. Well, come to find out, in outpatient services, it's just not cutting it for me. I need, I'm doing the things, I'm taking the prescribed measures and taking the prescribed services in an outpatient setting, but it's just not working because of the severity of my illness. Or I'm in an IOP program and I'm doing what what I need to do, and I'm taking, the recommendations, and I'm utilizing some interventions, but it's just not working because my recovery environment is so toxic and is not conducive to recovery that I need a level 3.1, right? So that's another reason. So any one of these can mean transfer or discharge, and those are your transfer discharge criteria. I've gone a few minutes over, so I want to wrap up. These are my references. Again, the ASAM criteria book has everything that you need in it. And if you have questions, you certainly ask what I do. I ask the people that are smarter than I am, or who know more about this than I do. And then also here is the third edition of the motivational interviewing book by Miller and Rolnick. I highly recommend that one too. It's been nice being here with all of you. Hopefully you got something out of this. And I again apologize for talking so fast. ASAM, I learn it all day long, every day, and I still don't know it all. So 1 hour, hopefully we did okay. Bye everyone, take care.